there. This is the moment that you have been waiting for. We are ready to code inpatient records. Now, you are ready to code inpatient records because you're on a journey to become a certified coding specialist. Inpatient coding is said to really be one of the hardest types of coding, and I believe that that's due in part to the fact that patients are sicker, the medical records are larger, and then just from the language of medicine perspective, the content that's in the medical record is a little bit more complex. So I want to lay a foundation that I want you to use as you dissect, pick apart the inpatient medical record, if you will. Usually, not always, coders start with a review of the discharge summary. Now, I said usually, right? Because in some settings, the discharge summary that is provided is written better than others. But the discharge summary should provide a recap of the hospital stay. So, as you're reading the discharge summary, there's a few things that I want you to keep in mind. In the inpatient setting, we're collecting the data according to the Uniform Hospital Discharge Data Set. And our ultimate goal for our purposes, those of you that are in the circle, we want to determine the MSDRG. So we're looking for the age of the patient. We're looking for the patient's gender. We're looking for the discharge status. But then we're also looking for the principal diagnoses. We're looking for the secondary diagnoses. But as it relates to principal diagnoses, secondary diagnoses, we're selecting them based on the guidelines that are found in Section 2 and Section 3 of the ICD-10 CM coding guidelines. Now, if you have not taken the time to review those guidelines, let me be the first to tell you, you're going to struggle because it's those guidelines that really lay the foundation for how we apply the concepts when we are exploring the inpatient medical record. Now, one of the things that I want you to know is that some say it takes 3 to 5 years to really get a flow going as it relates to coding inpatient records. And from a productivity standard perspective, inpatient coders are generally, not always, and why am I saying generally, not always, sometimes? Because every organization is different. So generally, coders are tasked with coding 3 inpatient records per hour. So, what does that mean? That means you have to approach the inpatient record with understanding the guidelines so that you can apply them. And it's not just Section 2 and 3. Oh, no. You have to be able to apply your chapter specific guidelines. So, for example, the record that we're going to start to explore together today is a patient who has HIV or AIDS. So immediately, you should expect that I may need to do a B20, or maybe I need to do a Z21. Does my patient have or currently had or previously had any opportunistic HIV infections? So there's all of these things, all the things that you need to know when you are attacking these records, in addition to medical terminology, anatomy and physiology, pharmacology, disease process, in addition to whether or not you need to query. And oh, don't forget, you may need to reference coding clinic. And so all of those things are a part of the process, which honestly is not necessarily a perfect science. So let's dig in a little bit. I'm not going to take you through this entire record, but I wanted to start you off with just the coder mindset as we're reviewing the record. And I want you to keep something in mind. You have to be patient with yourself during this journey. No one expects you to be perfect at this process. In fact, the Office of Inspector General even says that we can have a 5% error rate. Additionally, it takes time, and really, everybody is different, right? Some people catch on faster than others. The other thing is, as you're going through, you really have to think through the process. And there are going to be some information in the medical record that you're going to see that's going to just throw you off. And real world, sometimes information is brought forward from a copy paste perspective that does not apply to today's encounter. And so you need to be able to differentiate between what applies today for this hospital visit and actually what does not apply. So this is an old hospital visit that we're using, and this is for educational purposes for you to just really understand the process so that when you go and take your CCS exam, you are ready to attack and be successful. So this particular patient, you'll notice, was admitted on April 11th and discharged on April 16th. And remember, UHDDS, if you look at the AHEMA CCS exam domains, you need to know the UHDDS data elements. So, April 11th, discharged April 16th, and they went home. Okay? And remember, for our purposes, those of us in the circle, we're going to take this medical record and we're going to calculate the MSDRG. So once we start to dig into this record, we see that our patient is 51 years old at the time of service for this encounter. And I should note, when we use our encounter to calculate the MSDRG, we're going to use current dates of service. We're going to use this year's date of service because we want to get the MSDRG for now and not for previously, okay? So then the other thing that you're going to see is the principal diagnoses causing the admission. So one of the things that I want you to know, our physician partners, our provider colleagues, they don't go to school to learn coding. So they may have said the principal diagnoses causing admission is a cough, but you must remember that as the coder, you're going to apply the definition of principal diagnoses to determine what truly is the principal diagnosis, because the principal diagnosis is that condition that was established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. So we see now that there is an active hospital problem list. So this is where a lot of new coders get confused because they think, oh, these are all the problems that the patient has today. And unfortunately, in healthcare, the problem list is not always cleaned up, meaning it's not always current. So you want to follow secondary diagnoses guideline rules for determining if something is in fact a current diagnosis, okay? So, pneumonia is listed as 411, and our patient was admitted when 411. Okay. So, what you want to do is make notes of the diagnoses that you're seeing. We're going to call these your working diagnoses that you may ultimately code once you determine if they meet criteria for reporting, right? So, from a secondary diagnosis perspective, it's those diagnoses that require clinical evaluation, therapeutic treatment, increases the length of stay, requires nursing intervention. Secondary diagnoses per the guidelines. So, also, we notice human immunodeficiency virus. Now, this was 523 of a previous year. So, now, here again, B20, Z21, you're looking for those cues per guidelines to help you differentiate how you're going to go. If the documentation is unclear, that's when you know that you may need to query. But before you immediately say you're going to query, you got to read the entire medical record. Oh, did I mention you got to read the entire medical record? One mistake that brand new coders make is that they don't want to read the medical record, the entire medical record. And when I say brand new coders, brand new to inpatient coding. So you may have some experience coding outpatient, or maybe you're working in the billing capacity, but it's very important that you read the entire medical record. Okay, so we see some information about the patient's HIV status, and then we start to see some other conditions. So we see hyponatremia, which is from 411, that is during our hospital stay, but then we also see a fever. Oh, so now we're talking about another guideline that we may want to consider. Signs and symptoms. Signs and symptoms that are integral to a disease process are not coded when they are what? Integral, right? So from there, we see the medications. Now, one thing that you will want to note as a inpatient coder, and really a coder in general, it's important that you understand the medications that the patient is being treated with and how they correspond to the conditions. But now, please note, you can't say as the coder, oh, I see the patient is taking this particular medication, so I have the authority to assign a diagnosis code for that corresponding condition. Number one, you are not the provider. You don't have the license to treat this patient, right? It's not your patient. Okay. Number two, medications have multiple uses. And so you will want to confirm with the provider via his documentation, his or her documentation. Okay. So from there, when we look at the medications, whenever you see medications, you immediately want to recognize what condition that medication treats, right? So that as you're reading through the medical record, you can connect the medical record, the documentation to the condition. And so you're starting to develop and more of your process. Okay. So you start to see all of these different medications. And something that I really want to call out when you're reading the medical record, if there is a word that you don't know the meaning, that you don't know the meaning of, you must stop and look up the word. It doesn't matter if it's a medical word or an English word. If you don't know the meaning of the word, you have to look it up now. Because when you go and take your national exams, you're not going to have a dictionary in front of you, right? And then, real world, you're under a productivity time constraint. And so you don't have time to stop and look up each and every word. Start to embrace the language of medicine. Make it become part of who you are. All right, so after that, the record goes into a brief, and remember I mentioned every discharge summary is different. Some are short, some are long. Depends on the provider, okay? So from there, you see the brief hospital course. The patient is admitted with the cough and the fever. The patient's history is significant for viral encephalitis. So now, let me just explain something else. You're going to be seeing all of these conditions, and you're like, does the patient still have the condition? You have to pay attention as to whether or not the patient actually still has the condition. Why? Our physician colleagues will use the word history of, and the patient could actually still have the condition. And so you'll need to be able to determine based on the documentation if they actually still have the condition, because that's going to really determine if you're going to do a Z code or not. Okay. We will never be able to get them to change from, listing the word history. We just have to be aware. Okay. So then from there, they talk a little bit more about how the patient was treated, the antibiotics they were on, and all of that. And so then they talk about, how the treatment went, and then the patient was discharged home. So then from there, you see that we have notes from the emergency visit, because sometimes patients are admitted through the emergency room. And as it relates to hospital inpatients, not every patient gets admitted to the hospital. Why? The admission has to be medically necessary. So, an example could be like a patient that has asthma. And if they have asthma, the patient has to be treated as an outpatient. And if they fail outpatient treatment, they go to the emergency room, they try to treat them in the emergency room setting. And if the patient doesn't get better, then that's when they will make the decision to admit them. Even then, when they admit them, the goal of admission, my friends, is discharge. So every day, they're looking at if the patient continues to meet the criteria for continued inpatient stay. And so every day, they're evaluating, they're running tests to see, is it time to go home yet? Is it time to go home yet? Because being admitted to the hospital is not a vacation, right? The objective is to treat the problem that is acute. Any comorbid conditions, the problems that they come in there with, if those are problems that require the patient to continue the medications on, they will make sure that they don't make those problems better. That's the secondary diagnoses that you may have to code. But then it's time for the patient to go home, because the objective of admission is discharge. So they talk about, what happened in the ED, and then this is when, they make a decision. Oh, this patient's illness is so severe, it requires a higher level care, right? This is the patient that cannot safely be treated at home, so they have to be admitted. And so you know how the insurance companies are, right? They really want the patient to be sick enough to go upstairs to the deluxe accommodations at the hospital, where they have the little slippers and the little bucket with the soap and the lotion and all of that. You have to meet the requirements for that. All right. So in the ED, you start to see more about, the patient's history, right? They ask you about drinking and smoking and all of those different things. They do a review of systems. The review of systems is not the exam. It's a series of questions to rule out what is or what not may be going on. It's a chronological review of the different systems of the body. But the provider is not touching the patient, okay? The touching comes in during the physical exam. So from there, the physician is going to be examining the patient. So usually in this type of setting, depending on the problem, they're doing a head to toe physical examination, right? They're trying to see which systems are normal, which systems are not, based on the patient's presenting problem, so they can isolate what's actually going on with the patient. And so from there, they're listing out the negatives and the positive findings from the physical exam. They will order diagnostic tests. So you see x rays and EKGs and blood work. And this patient was also given interventions in the emergency department. Again, they're in the ED, and the goal is let's try to get them home and not upstairs. So from there, they're listing the lab results and they're listing the impression and the plan. So at the end of the first paragraph, or this last paragraph here, the patient did not show at this time evidence of respiratory fatigue, although he needs to be closely monitored at this time. They talk about some critical care, and then they list diagnoses: pneumonia, malaise, fatigue, HIV, hypoxemia, tachycardia, fever, right? They are monitoring the patient. So now you see an H&P. So as the inpatient coder, after the discharge summary, the next document that we will generally review is the H&P. And so the H&P will include things that we saw in the discharge summary, but it may also include lots of things that we didn't see in the discharge summary. It will also include some information that you may have seen in the emergency department note if there is an emergency department note, okay? So then from there, you see the initial H&P. All hospital visits have to have an initial H&P, all right? So from there, um, the doctor says, they reviewed the lab tests, the hyponatremia has improved. They talk about the chest x ray consistent with pneumonia. So now the $1,000,000 question is consistent with an uncertain diagnosis. Because if you are a coder that's been coding in the outpatient space, you may say, oh, that might be an uncertain diagnosis. So here, where the rules come in, your guidelines. But this also may be where you need to reference Coding Clinic to see what Coding Clinic says about whether or not this is truly an uncertain diagnosis. Inpatient operates differently as it relates to uncertain diagnoses compared to outpatient. Now remember, for purposes of the CCS exam, part of the time you're going to be inpatient coder, the other part you're going to be outpatient. So you have to wear both hats, okay? All right, so the assessment and plan. We got pneumonia, we got fever. So the question is, do I code the fever? So one reference I will tell you that I use quite frequently is the Merck manual. And one of the things that I love about the Merck manual, so the Merck manual for professionals, not the Merck manual for consumers, the Merck manual for professionals really, it gives me the diseases. It gives me an overview of the diseases. It gives me the signs and symptoms, the etiology. It gives me the tests that the providers are going to use to evaluate that condition. It tells me about prognosis. It tells me about surgical options and different interventions. It helps me as the non-physician understand the condition. So when I'm reading it in the medical record, number one, I know if a sign or symptom is integral to the disease process and not separately coded. All right, so usually with the assessment and plan, every diagnosis will have the diagnoses followed by what the plan is, usually, because every provider is different. All right, so from there, you read, and again, some of the diagnoses you've already have on your notes from the discharge summary. And so you'll just say, check, yep, my patient definitely has that. And so then there will be others that you will add. And as you continue to go through the record, because this is where I'm going to wrap up, you're going to confirm the diagnoses that the patient has. Now, is that all we do? Absolutely not. So, you're going to be reading progress notes. And via the progress notes, you're going to confirm diagnoses that continue to meet the criteria to be reported. But you may also see, in addition to progress notes, you also are going to see consultations. And you may also see surgical reports that then require reporting of an ICD 10 PCS code. Now, please remember, as the inpatient coder, we're not necessarily going to pick up things like chest x rays and EKGs because those are services that are going to be captured by the hospital charge master. So we are not going to pick those up. So read through the record and capture what you believe should be coded. And so when we get together, we're going to find out what you identified should be coded for your 25 inpatients that were assigned to you.